Hello, professors and classmates. My name is Adriana Gillespie, and I'm a family nurse practitioner student from United States University. Today, I will be presenting a soap note on geriatric pulmonary. My patient is LS, date of birth 3/18/1959, 66-year-old Caucasian female, presents to the clinic by self and seems to be a reliable historian. LS is a 66-year-old Caucasian female with a past medical history of hyperlipidemia, osteoporosis, and obesity, who comes in the clinic with complaints of annoying cough that does not seem to go away for the last week and a half. The patient reports she had a cold 2 weeks ago, and a few days later, the cough developed and has not gone away. She denies fever, chills, and unexpected weight loss. She admits to fatigue, headache, throat irritation, and decreased appetite. Additionally, she reports chest discomfort and productive cough, which was at first dry, but now has become thick, yellowish color phlegm. Nevertheless, she denies shortness of breath, and she denies nausea, vomiting, diarrhea, and no other medical concerns. Her past medical history includes hyperlipidemia, osteoporosis, and obesity. Patient reports no allergies, including to medications, foods, latex, or seasonal allergies. She's currently taking rosuvastatin 20 milligrams daily, Prolia 60 milligrams every 6 months, magnesium 200 milligrams at night, and vitamin D daily. She reports she's up to date on all her vaccines, including pneumonia vaccines. She had a flu shot last December, original COVID vaccine, but has not had boosters. Her social history shows chemical history, denies current or history of alcohol, tobacco use, or illicit drugs. The patient's family history shows that her mother is an 85-year-old female alive with a history of hypertension, asthma. Her father deceased at 72, hypertension, smoker, and COPD, and her sister alive at 63 years old has obesity, hypertension, and asthma. The review system shows she denies chills, fever, and recent weight loss. However, she admits to fatigue and decreased appetite. The headache, she denies trauma or lightheadedness, but she admits to headaches. The nose, she admits to nasal congestion and rhinorrhea and denies sinus pressure. She admits to throat irritation and hoarseness, denies sore throat or difficulty swallowing. Her cardiovascular was unremarkable. Respiratory, denies wheezing, difficulty breathing, or shortness of breath, admits to chest discomfort and productive cough with phlegm, yellowish color. She denies dizziness and admits to headaches and denies GI symptoms. Her vital signs include temperature of 98.7, pulse 87, respiratory 20, blood pressure 135/78, O2 saturations at 96%. Her pain is a 3 on a scale of 0 to 10 for a headache. She weighs 255 pounds, and she is 63 inches tall. Upon physical assessment, the patient was a pleasant female, alert and oriented, appeared tired and fatigued, but in no acute distress. The nose, nares were patent erythematous, mild congestion. The throat was erythematous posterior pharynx, no exudate, no sinus pressure or non-tender. The lymph nodes, there was no cervical lymphadenopathy. The lungs are clear to auscultation bilateral on both inspiration and expiration, and they were resonant throughout, with absent adventitious sounds. The heart and neural and GI were all normal, and her extremities, there was no clubbing or cyanosis, and capillary refill was less than 2 seconds. The differential diagnosis includes acute bronchitis. The rationale: this is the most likely diagnosis, as viral acute bronchitis is characterized by an acute cough due to irritation and inflammation of the trachea and the large airways, without evidence of lung infection. The patient's review of system and physical examination presents with fatigue, headaches, nasal congestion, throat irritation, hoarseness, chest discomfort, and productive phlegm. But her lungs were clear on auscultation, which suggests common signs and symptoms of a viral bronchitis. The second diagnosis could be pneumonia. This diagnosis is less likely as the patient did not present with any signs of lung infection, such as tachypnea, tachycardia, fever, chills, or shortness of breath. Asthma is the third diagnosis. Because of the patient's familial asthma history, this diagnosis can be considered. However, the patient's missing report of wheezing, shortness of breath rules out this diagnosis. Nonetheless, if the symptoms of cough worsen with the presence of chest tightening, wheezing, or shortness of breath, this diagnosis will be closer considered and assessed. The diagnoses that were done in clinic included a rapid influenza nucleic acid amplification test, which showed negative for influenza. Imaging is not recommended at this time unless the symptoms worsen, such as she becomes dyspneic, she has bloody or rusty sputum, or elevated heart rate, fever, or lung consolidations are suspected. The treatment: because this illness is most likely caused by a virus, no routine antibiotics therapy is recommended for acute bronchitis. If the patient has difficulty sleeping, however, dextromethorphan can be used, 30 milligrams at night for 7 days and no refills. Patient can also use honey to manage symptoms and soothe throat irritation with warm water. Because lungs were clear on auscultation with no consolidation, no beta-2 agonist like albuterol will be prescribed at this moment. The patient will be educated that the cough can last for another 10 to 14 days. She needs to increase fluids and rest, and education about antibiotics to not shorten illness or cause resistance should be given. The patient needs to follow up if symptom worsens or she develops difficulty breathing, immediately to head to the ER. Thank you.